Hello, and welcome to Health is the Key, the podcast that explores the health and wellness issues that matter to 1199 SEIU healthcare workers. I'm your host, Elizabeth Moore. It seems everyone is talking about GLP-1 medications these days. First developed to treat diabetes, the drugs quickly gained attention for the role they play in weight loss. But despite all the buzz, there are still a lot of questions. What exactly are they? How do they work? Are they safe? So today we're talking with Dr. Holly Lofton, Director of the Medical Weight Management Program at NYU Langone. Dr. Lofton will share answers to these questions and others and explain why it's so important for patients taking these drugs to work closely with their primary care physician. Welcome to Health is the Key, Dr. Lofton.
Thanks so much for having me here, Elizabeth. I appreciate you inviting me.
So, as we said, everybody's talking about GLP-1 medications, but what exactly, if you could give us a brief overview, what exactly they are, how they work, how they affect your brain?
Well, GLP-1 agonists mimic the native GLP-1 that we make in our body. Every time we all take in a meal, the intestines create GLP-1, which is a hormone that goes to the brain and eventually tells us to stop eating. So that's why we don't just eat constantly. It also slows down the rate the stomach empties so that you can absorb the nutrients from your food. And a third part of it, which is very important but often forgotten, is that it makes us more insulin sensitive, meaning we make our fat cells less stable so they can shrink more. So that's really the mechanism of the GLP-1 agonists. They decrease appetite, increase fullness, and help our fat cells shrink hormonally.
We know that they were originally developed to treat diabetes, so they have been tested, but are they safe for weight loss in general?
So every one of the GLP-1 agonists and medications in similar classes have been tested for both safety and efficacy, or how well they work for weight loss, and in specific populations, some only in adults, some also in children as young as 12 years old who meet the conditions for weight management medications. And that's specifically BMI 27 and higher. And some of them have medical conditions and some of those participants don't. So that's where they have the cutoffs for who can get these medications for weight loss.
Mm-hmm. And that brings us to what makes a patient a good candidate for a GLP-1?
So what makes a patient a good candidate is that they have obesity or overweight as a medical condition. So this is generally diagnosed by body mass index, which is a height-weight ratio, which can be easily calculated. Other ways we look at this definition would be measuring body fat percentage by various methods, whether that's using DEXA scanning for body composition, or there are some fancy scales doctors use to determine your fat mass and muscle mass. Another is waist circumference, which is also very easy to measure, looking at waist circumference. If it's over 35 inches in a female, or over 40 inches in a male, that can be a diagnosis that hints toward overweight or obesity. And we should also make sure that patient has tried lifestyle before we consider medications.
And so what would make someone not a good candidate? Are there certain patients who should not take GLP-1s?
That's a very important question. So we want to make sure we're not giving it to patients who has not been tested on. In all of the trials to get these medications on the market, anyone with a personal or family history of medullary thyroid cancer or another rare endocrine condition called MEN2 neoplasia was excluded. So it's not for those patients if they had those conditions themselves or if their family members had it. And there are some medical conditions that are excluded. So pancreatitis that has been chronic or pancreatitis recently is generally a contraindication to taking GLP-1 agonists. Another, what we call relative contraindication, meaning some people can take it, but most people can't, is if they have a condition called gastroparesis. And gastroparesis means slowing of the nerves that treat the stomach and help it empty. And that tends to happen in people with poorly controlled diabetes. Their stomach just doesn't empty properly because of nerve damage. And because the GLP-1s do slow down your stomach more, it's not recommended for those people.
So when a patient comes to visit you and is investigating GLP-1s, how do you approach it? Obviously taking a family history and things like that, but how do you ascertain whether they're a good candidate or not?
Well, first we get all the information such as their vitals, labs, examine them, ask about family history, their personal history, and then we want to get an idea of what the patient's individual goals are. Weight, of course, is a primary one, but we want to know the goals beyond that. What about your health? Are there certain activities you like to do that you can't do now, such as ride a roller coaster or go upstairs comfortably? Those are the long-term goals for weight management, but we determine if GLP-1 agonists can help the patient reach their goals, both for health and their personal reasons.
So you look at the whole person.
Yes.
So, and when would, if a patient starts, when would they start seeing results?
When the results start really varies because everyone's physiology is different, and that's something very important to remember. These medications are titrated up, and that means everyone should start at a low dose and then increase based on their tolerance, meaning their side effects, and their response. So some patients stay at the lowest dose of GLP-1 and reach their goal, and they don't ever need to go up higher. Some patients don't get results until 5 or 6 months later when their highest dose. And that's why it's important to individualize care with your prescriber.
And you had mentioned side effects. We hear a lot about there's a controversy a little bit. Some say there are significant side effects. Some say they're not so bad. What is your experience?
Well, I think the idea that there are significant side effects depends on talking to individuals versus looking at a whole. So when you look at the trials, all of the trials have the medications with the most common side effect being nausea. And that varies to different doses and different medications. So, for example, looking at tirzepatide, which is Zepbound for weight management, the nausea at the highest dose is about 25%. Whereas you look at Wegovy at the highest dose, it's about 44%. So that's where those numbers come from. But none of those numbers are above 50%. So that means most people don't actually have side effects. The way I like to tell people is that the people who do have side effects are very loud about them and will tell you about them. And there are people who are coasting under the radar, not having side effects, feeling just fine, who just don't mention it.
Right.
So it's up to the individual to see if the side effects are present, what's present, and then if they're tolerable. And then as prescribers, we adjust the dose based on that, but also optimize a lifestyle. So if you start someone on a medication, you don't tell them what to eat, what not to eat, they're more likely to have side effects.
That's so important what you mentioned, lifestyles. So when you prescribe a GLP-1 for a patient, how important is the lifestyle? How much do you consult with them about that?
Lifestyle is essential to weight management, independent of how you're doing it. Whether you're using medications or having surgery, lifestyle is the basis. So every patient I see initially, immediately after me, sees a registered dietitian. And they give them individual lifestyle recommendations based on their likes, their dislikes, their ability to move, and if they have any food allergies or intolerances. And that's adjusted over time because our protein goals are changing as we lose or gain weight. So are our fluid goals. So that's always something that's really important to address, especially when we're starting a medication, because the medication is doing something for your body. And if you have the benefit of the lifestyle as an adjunct to that, you get more results earlier.
I had heard that you do, as with many weight programs, you do plateau after a certain period. So working the lifestyle aspect into the GLP-1 medication is really important.
Well, I tell everyone this. You will reach a plateau. I promise no one will lose to zero. So there will always be a point where you stop losing. It does not necessarily mean the medications stop working or that you're not trying hard enough. This has to do with the fact that the body does not like to lose weight, and that's why we have medications like GLP-1. So when your calorie intake reaches your energy expenditure plus what the medication will do, that's when your body just stops losing weight. And then we look at, is this enough weight loss? Is this plateau just fine? Can you stay here forever and your health is great? Or do we need more weight loss? And then we look into other measures, whether we need other medications or for patients a candidate for something like bariatric surgery.
Okay. And part of the lifestyle approach is diet. So what is the ideal diet for someone on GLP-1?
Well, I mentioned that the diet rules haven't changed, but we're more aware of them lately. So my rule has always been protein every meal. And proteins can vary. I'm vegetarian. I tell my patients who are vegetarian, you can still get protein. There are things like eggs, yogurt, cottage cheese, meat, poultry, fish, tofu. And there's also protein in the shells of legumes. So we have a few sources of proteins that can usually fit into someone's diet. And then we want the fiber content to minimize the risk of constipation, but also to increase fullness. The more fiber we eat, the more our stomach stretches, the more we feel satiated and for longer. And we want to meet our needs for fluids. Generally, I tell patients to take their weight in pounds and divide that in half, and that's how many ounces of water you should be drinking a day. If it's not water, something like water, less than 10 calories a serving. And that number will change over time, too, as your weight goes up or down. And then we want to make sure that the patient knows that they shouldn't overly restrict. You should eat when you're hungry, stop eating when you're full, and then maximize what you feel you can take in, even if your ability to eat food decreases as you are able to increase the dose of medication. And they should give feedback to their provider if they feel they can't meet those goals, because that may necessitate a dose decrease.
So working with your provider and or a dietitian is very important.
Yes.
Cool. And so what we've talked about is that this is not a magic bullet. GLP-1s are not a magic bullet. There's always going to be a lifestyle component. How does exercise, sleep, all the usual things for a healthy life play into this?
Those are really essential too, because GLP-1 is a hormone, and there are so many hormones in our body that can influence our appetite, our fullness level, and our energy levels as well. And one of those has to do with insulin, which the GLP-1 helps. But if we're not getting enough sleep, that can affect our leptin levels. And leptin is a hormone that actually makes us have more hunger. If you're not getting at least 7 hours of sleep throughout the night as an adult, your leptin levels go up the next day, and you're going to be more hungry outside of the GLP-1, outside of your best efforts. So maximizing the opportunities to get sleep is very important. And then the exercise is important because we want our metabolisms to stay fast as we lose weight. If our metabolisms drop too much, then it's going to be hard to maintain. And this is evidenced by the Biggest Loser study. If you ever read it, the people who did the Biggest Loser show, they did a lot of exercise, they ate very little, and it was almost impossible to maintain because their metabolisms dropped too much. So that's actually something we measure in the office is patients' metabolism when they get to the lowest weight or their plateau or goal, so we can tell them how many calories they need.
And it's what you talked about, sustainability too. It's just being able to sustain that sort of exercise regimen and diet in your life. Life intrudes, so you have to get something that you can stick with for a long time.
Exactly, but it's also possible for the environment to change, and it's constantly evolving. So if someone gets a new job, has a baby, their ability to do the exercise that they once did may need to be adjusted, and thus we might need to adjust the lifestyle recommendations from the food perspective and even the medications.
And I wanted to ask you about the weight gain after stopping. That, too, is controversial. We hear that it comes back immediately, and other people are saying, no, it doesn't once you've learned the lifestyle component. What is your experience with that?
So I'll give you the scientific answers for this first, and I'll reference 2 trials that were done with semaglutide. It's called STEP4, and with tirzepatide, it's called SURMOUNT-4. And they gave everyone lifestyle recommendations throughout the whole trial, and they put all the patients up to the highest dose of those medications, and then they either continued or went straight to placebo. So they went from highest dose to 0, or they stayed on the highest dose. Those who went to 0 had weight regain starting at about 6 weeks. And even though they continued the lifestyle recommendations, so about 2/3 of that weight that was lost was regained after about 6 months. And then the trial ended. So we don't know what happened, if they would have regained everything or more after that. Now, we're looking at this as a trial. Trials are giving you numbers that are averages of about 3,000 people. So that tells us that some people did maintain weight and some people gained weight faster. So we consider the trial off if someone wants it to be a trial. Let's see what happens if you discontinue. And if you start gaining weight, then that means your physiology warrants staying on the medication.
And I wanted to go back a little bit to what we were talking about, diet. Are there foods that you definitely need to avoid if you're taking a GLP-1?
Well, other than the foods we tell you to avoid when you're trying to lose weight, we don't want you consuming mostly cookies and donuts during this. But in general, there are some foods that can increase your risk of side effects. So just as the GLP-1 agonists slow down the rate your stomach empties, fatty foods slow down the rate your stomach empties. So those are generally foods that are fried, very cheesy, very oily, and also alcohol. So I tell patients not to mix fat and alcohol. And they say, well, I won't do that. And I say, well, think about it. Sporting events, this tends to happen, and parties, because those are the foods that can stay out for a long time and not go bad, and they're easy to fix. So the mix of fat and alcohol, for example, wine and cheese, that is going to increase the risk of nausea and vomiting in patients taking GLP-1. So I just ask that people don't overconsume those.
And is it possible if people don't follow the lifestyle recommendations and do stay on the GLP-1s, that they will achieve weight loss, but it just won't last as long? It'll take them longer to get to the plateau? Or how would that work if they just ignore lifestyle recommendations at all?
I can tell you I've seen just about every outcome that can occur, and it's quite variable. But we have to remember these medications are binding to receptors that we have in our bodies, so how well they work depends on how many receptors for GLP-1 you have in your body. So there are some patients who can make minimal changes, not exercise, and lose more weight than the person who's doing everything they can and is at the highest dose. But generally, you want to give that first 6 months during the titration period of the medication your best efforts at lifestyle to, one, keep your metabolism fast, maintain your muscle mass, and just develop the general habits that are going to help you maintain weight later on.
So that gives you a head start.
Yes.
I did want to ask you about any medication that you may be on, if there are any complications with taking GLP-1s.
There are different GLP-1s. So if we look at medications such as tirzepatide, it slows down the stomach significantly. And if you're taking oral birth control pills, they could not get absorbed well enough to prevent pregnancy.
Oh.
So I warn patients about this when we start the tirzepatide. If you're taking oral birth control, we don't expect it to work to prevent pregnancy for the whole period you're titrating the medication up, which could be 6 months. So they should be on a different medication or something non-oral like an IUD, or use barrier contraception to avoid accidental pregnancies. And I've actually seen the birth control pills fail, and we have accidental pregnancies, so that's really important. With the newest one, which is Foundayo, it is metabolized by the liver, so there are some drug interactions with various classes of medication that inhibit a certain enzyme called cytochrome P3A4. And there's a long list of those I won't get into. And specifically with that one and simvastatin, a cholesterol medicine, if you're taking Foundayo, it's not recommended to have more than 20 milligrams of simvastatin, because that will increase the concentration of the simvastatin in your bloodstream, and that could lead to some problems with the liver.
So another good reason to work with your primary care physician while you're on these drugs.
Yes, patients should really disclose any medication changes that they are noticing or prescribe, even supplements when they're taking these medications. Because, for example, St. John's wort people take for depression can interact with Foundayo.
That's interesting. And I'm glad that you had brought up the tirzepatide.
Yes.
So there's tirzepatides, semaglutides, and liraglutides. Does the patient need to know which one they're getting? And how does a doctor determine which one they will prescribe?
Well, I'm glad you stated those out with their scientific names. So in order of how they came onto the market, liraglutide is a daily GLP-1 agonist, and it's known as Victoza for diabetes and Saxenda for weight loss. And so it's a daily injection. It's our first injectable GLP-1 that we use for patients because it was daily and that's all we had and people used it. We don't use that one so much more because we have the weeklies. But for someone who I'm concerned about side effects, I actually might start the daily just to find the right dose so they don't have side effects for a long time. Then the next one on the market was semaglutide, which is Wegovy for weight management, and Ozempic for diabetes. And this average weight loss is about 20%. When it came out, this was the most weight loss of any drug that had ever been on the market for it. And this is a weekly injection. And then the most recent injectable is tirzepatide, which is Zepbound for weight management and Mounjaro for diabetes. And the weight loss with this one, depending on the trial, is about 20 to 23%. So the difference in this one and the others, so tirzepatide affects two agonists. It's not only a GLP-1 agonist, it also affects another hormone called GIP, which the letters don't add up, but it stands for inhibitory gastric polypeptide, and that slows down the stomach more, but it also has a direct effect on metabolism because it makes fat cells smaller directly, whereas the other GLP-1s do so indirectly. So we do see more fat mass loss with tirzepatide than the others because it is a different molecule.
So should a patient know which one they're on? They should speak to their doctor about it?
Absolutely. Yeah. Should always ask, what I'm taking. I think it should be the prescriber telling you this is the medication you're taking, but they should be given the choice of the pros and cons individually of which one they're taking. Now, you can switch back and forth if you need to, but that should be done on an individual basis too.
Well, you've given us a lot to think about, and we've given us a good overview of GLP-1s. Are there any additional lifestyle supports that would help facilitate success that people might not think of?
Well, I think that we should optimize activity when we can, because we can't always. Sometimes patients will get an injury for some reason. They fall and they hurt their knee, and if you have a hiccup like that, the fact that you started early with your activity can really help you not gain weight if you can't exercise for some reason. Also, drug interactions. Not really with the medications, but some drugs cause weight gain. So another reason it's really important to share the drugs that you're taking with your doctor. And also, if you're prescribed any new medications, ask that prescriber, what's the weight gain potential of this medication? Because some antidepressants or medications for anxiety or even sleep can cause weight gain. So that's something we should really keep to the forefront.
Those are great questions to ask. Does the emotional support come into play with GLP? People think of it as medicine, and then, well, I don't really need the emotional support, but that is kind of a factor, isn't it?
Absolutely, because we have to think about those around us, and not only if they're supporting you trying to lose weight, but also what is their take on you then losing weight, because sometimes this can be positive and sometimes it can be negative. So it's important to know that as people change their weight, they want to maintain those relationships. And with regards to mood disorders, they commonly coexist with obesity or overweight. So I always screen for anxiety, depression at the initiation of a GLP-1, not because the medication itself can change the likelihood of those occurring, but just to have that support as you're losing weight. Because sometimes as you are eating less, you lose a friend that is food. And that can become upsetting to some people, and we want to make sure we have something to fall back on instead of that.
That's great to look at the whole person. Well, thank you for answering all our questions about GLP-1s. Is there anything you would like to leave our members with?
I do want to comment on the popular belief that muscle mass is lost excessively with taking GLP-1s. So this has actually been scientifically studied, and there is not more muscle mass loss than you would if you lost that same amount of weight with diet and exercise. So what's really happening when you lose weight, generally every 10 pounds lost is about 7 pounds of fat and 3 pounds of muscle. And that's because the smaller body does not need as much muscle to move as the larger body did. So if you were carrying a 30-pound backpack on your back all the time, you need more muscle, and you take it off, you don't need as much muscle to carry that around. And what people may say, my muscles look smaller, we have to remember that within the muscle belly, there are some spots of fat that are absorbed and used for energy when you're losing weight, whether you're using GLP-1s or not. And thus the muscle belly can look smaller, and that's actually the fat loss there. So in this study I was referencing, they found that patients who were taking GLP-1s and using lifestyle actually were 3% more muscular after they reached their weight plateau than when they started, because they lost much more fat mass than muscle mass.
Wow, that's interesting. Well, thank you so much for joining us today. We really appreciate your time.
Thank you.
Tune in later this month to our July keynote to hear Dr. Lofton break down the differences between injectable GLP-1 medications and the newer pill forms now available. For more information on what you heard today, please check our show notes. And remember, subscribe to Health is the Key wherever you get your podcasts. This podcast and its content are presented solely for general informational and entertainment purposes. The information and opinions provided on this podcast are not intended as legal or medical advice and do not constitute or serve as a substitute for professional medical or psychological treatment, diagnosis, therapy, or other types of professional intervention.